He's the CEO and chairman of Agma Biomaterial. His presentation today is titled Bone Graft Cements from Evolution to Revolution. His presentation will explore the potential and new opportunities of using cement-based augmentation materials in the maxillofacial and dental fields, and emphasizing the advantages, disadvantages, and methods of use for the scientific and clinical points of view. Welcome, Dr. Yahav.
Thank you very much. First, I would like to thank to the organizing committee for inviting me here. It's a great pleasure, privilege, and honor to be here. And of course, I would like to thank you all for sharing your time with me in this late afternoon. Today, I would like to speak about advanced augmentation solutions by using bone graft cement. Simplicity is the ultimate sophistication. Statement made by Leonardo da Vinci a few hundred years ago. It was right then, and it was right now. How many of you would imagine themselves lighting a fire in that way when you have a matches in your hand? Probably, the future in our field, very few of you will imagine yourself working with granules and membrane when you will have cement in your hand. So the question is, why cement? Cement actually changed all of the construction field since they have been founded. It changed the orthopedic field, and now it's our turn. Bone cement, suitable bone cement for our field as well. Actually, up until now, we are working with granules, patties, in order to improve the handlings. Those patties can be those that we can purchase, or those that we can make by ourselves. And of course, blocks, which are completely different techniques. So we are all familiar with those techniques. If we work with blocks, we need to shape them, to stabilize them. It needs some experience. If we work with granules, the same. We need to stabilize them in place to prevent their movement. Normally, we need to use membranes, which is additional cost for us. And fairly, we can have some volumetrics results. Now, the question is, are we going to have regeneration or repair? Are we going to speak about true bone regeneration, or are we going to have, in the end of the day, some kind of repair? But mostly, the grafted site will be occupied by our graft, and not necessarily by the bone. So if we're looking in this core, this is a core which was taken from material that does not resorb. 80% of the core is a non-vital bone. If we will look about material that is replaced completely in the patient on bone, we are talking about 100% regeneration. But we need to understand, it's not enough that it will resorb, because when it resorb, it can be also connective tissue, not necessarily bone. It has some, it need to have some ability to induce the bone to be formed in that area, and then we might have 100% regeneration. Now, when we use a material that resorbs simultaneously with the bone formation, actually is a short-term space maintainer. And we know that if we want to have success in augmentation, there are two essential requirements. One is space maintaining, the second is graft stability. No matter what kind of graft we are going to use, if we will not respect those two essential requirements, we will not have bone in that area. So, if we are using something that replaces even simultaneously with the patient on bone, it's a short-term space maintainer. Therefore, sometimes we need to create a composite graft. A composite graft can be a mixture of two different augmentation material, which can be a mixture of autogenous bone graft with xenograft, or any other augmentation material with different behavior, in order to gain a little bit more vital bone in the area. So in the end of the day, we will have much better result than this one. So when we work with granules that are not resorbed, actually the bone that can be formed is just in between those tiny spaces that exist between the granules. Therefore, we are always being taught not to condense our granules, because probably if we do so, we will not have bone. After even 6 months, we're going to find some granules that were not integrated. Now, if the graft is in a good quality, we will speak about integration. Integration? Where is the regeneration? And by the way, no matter if you use allograft, no matter if you use xenograft, the only regeneration that you might have is maybe if you use autograft. But integration, it already shows us that there is no regeneration. There is a small regeneration in between those particles that were integrated. And if the graft is in a good quality, we might speak about functional continuity between the graft and the bone, and then definitely we can have some good volumetric result. We can have something that will work. We need to wait normally about 6 months, 5 months, until we have a solid mass that we can place or load our implants. So always, there will be those who will say, why should I care as long as it works? And true, it works. But I think it's the same as for those who will say, why should I care as long as I sleep? Because definitely, you can choose to sleep in that way, or in this hotel, or in this hotel. Everything is a matter of standard that you define that you want for yourself. So let me summarize what are the existing drawbacks of the grafts that we have today. And please, if somebody thinks that I'm wrong, please raise your hand. They are difficult to stabilize and to work with. Therefore, they prolong our chair time. In the end, we have a limited amount of vital bone. Therefore, it's prolonged the healing period. Membrane coverage is essential. Therefore, it's increased our costs. So as my uncle say, bone cement is a different concept. But as a different concept, it can give us a different possibility, but we need to understand the concept before we start working with it, because it's completely different than what we've been used to work with up until now. So let me show you a video that was made by Professor Ziv Mazor. I'm sure that some of you are familiar with him. Here we did one part with cement. Near it, we use granules. So first you activate the cement. The only thing that you need to do is to eject it into the side. It sticks to the area. You press it for 3 seconds, not more than this, and you're done. No need for membrane. If you want to add, you can always add. And if you add, again, press it again for 3 seconds and close your flap. Now, if we work with granules, first thing that we need to do is to take a barrier membrane. We need to mix our granules with something in order to improve their handling. And I think everybody can see the difference. A video is better than 1,000 words. Now the question is, what will be the results? And definitely we shorten the video because probably it would stay much few minutes. Now, of course, we need to close it, primary closure, tension-free, which is very important when we work with membranes. 3 months post-op. That's how it looks before, the cement area, and this is the granules area. And this is the bone. And this is the granules area. You can see the deficiency of the bone due to the granules movement. So, about 20 and something years ago, I wanted to make it differently. I wanted to find something that will change our world of augmentation procedure. So I knew that cement might be the solution, and I went into the literature to find which kind exists for us that we might use it in our field. Calcium phosphate cement has been used since 1982 in the orthopedic field. Since then, there was a big change in that field. Most of the grafts are cement in that field. For our calcium phosphate is not so suitable. We have different requirements. So the only one left was calcium sulfate cement. How many of you are familiar with calcium sulfate? Please raise your hand. Very few. But it's not true. All of us know what is calcium sulfate. It's the plaster of Paris. The most simple and inexpensive material that exists. It exists in the construction, it exists in food, it exists also in medical. Of course, in medical, we need to have a medical grade. Now, this calcium sulfate was first used in augmentation material by Driesman in 1892. He closed the gap of tuberculosis with the material. Surprisingly, he saw that the bone was formed there. And there are thousands of articles about it. Now, when I went into the literature and I started to review those articles, I was shocked. What are the characteristics of this material? So I will summarize some of them. Okay? The material is non-toxic, extremely biocompatible material. There is no host response. It has the similar, and some articles say that even better outcome than autogenous bone graft. Very impressive. The resorption profile of calcium sulfate is identical with the bone formation rate. What can be better? It has the ability to stimulate bone growth. It's not osteoinductive, but it's a bioactive material. And by the way, all of the mechanism of action of calcium sulfate is not integration. When you place the material, the only time that it comes in contact with the bone is in the moment that you place it. Immediately start the degradation, a release of tons of ions of calcium, which start in a biological process to precipitate in the form of HA and calcium phosphate lattice work of the bone. Now the presence of ions of calcium encourage the pluripotential stem cell to differentiate into osteoblast. And it's not what I'm saying. This is the literature. Just go to PubMed and read about it from all of the fields. Amazing. We are talking about regeneration. So, how many of you using calcium sulfate? Please raise your hand. Very few. What's wrong with it? That's exactly what I asked myself in that time. Because I saw that it's self-reinforced, biocompatible, cementable material, totally replaced by the bone, promote bone formation, excellent hemostatic material. If there is exposure, almost never it will get contaminated. It has some bacteriostatic nature due to its salt properties. And of course, it's not expensive. So what prevented it to be popular? There was two drawbacks that along those 100 years prevented it to be popular. And I knew it. First one, it's an absolute one. It says that calcium sulfate cannot set, cannot get hard in the presence of blood and saliva. Therefore, those who wanted to work with this kind of material needed to absorb all of the blood, to place a little bit the material, to wait, to place another increment, to use some additives and accelerators, and even so, it didn't set. Why? Because the crystals of the material get contaminated with the blood and actually could not form a hard mess. So I say to myself, this is a challenge. The other said that it has a fast resorption rate. Well, company who wanted the material to be more stable, they did the setting outside in the plant, then they grind it into pellets in the orthopedics or granules into the dental field, and then they found that it has simultaneous resorption with the bone formation, okay? And has a predictable resorption, but it's a short-term space maintainer. So I said, short-term space maintainer, if it can be predictable by protocols, we can use it in the best way. Why? Because if I ask each one of you now, what is better, hard or soft? Probably you will say, depend for what. So this is protocols. But I knew that if I couldn't resolve this problem, I didn't do nothing. So it's become like an obsession to me. And it took me about 15 years of development. Because I didn't want to add any polymers, because when you add polymers, it's a different material. I didn't want to use any additive, and I didn't want to use any accelerator that will raise the exothermic reaction. Even so, company that tried to add accelerator, the material did not set in the presence of blood and saliva. So after those 15 years, we created the biphasic calcium sulfate. Now figure out that all of this patent, all of this invention is based that most of the particles are already after their crystallization, but still each one of them has some tiny places that has the ability to behave like cement. So now the material is much more stable. The pH is neutral. It can set in the presence of blood and saliva. Okay? But still, it's a short-term space maintainer. So we have two products. We have the first blue box, which we call it the 3D bond. It's a pure biphasic calcium sulfate. However, remember, it's a short-term space maintainer. If it's a short-term space maintainer, the only indication that can be used is when we use it for socket grafting from first central until second premolar, or molar with a septum. If we will use it in a different indication, probably it will resorb too fast. And it's very important to remember. The other product is a combination of 66.6 biphasic calcium sulfate matrix and 33.3 HA high density in a controlled particle size distribution, which means that we have particles from 90 micron to 1 millimeters, but not just that. The form of the particles are completely different one of each other, because we know hydroxyapatite is not supposed to resorb unless you give him the condition to do so. So actually, after 4-5 months, most of the small particles to medium side will resorb as well. Now, in order to remember, I brought this wonderful Bugatti car. High performance, but it cannot be off-road, which means that if you want to use the 3D bond, the blue box, use it just within the indication. Indication, first central until second premolar, molar with a septum. Not when you have thread exposed of implants. Not when you have a periodontal defects, which are not surrounded by enough bony walls. It wouldn't work there. And the result, 100% of regeneration. We can see the microcity is the same form of the bone. We can see the histology. It's 100% patient-owned bone. And we can see the osteocyte, which reflect this is a vital bone. 3 months are enough. The same as those 3 months when we don't do nothing. We just leave the blood clot to do the work for us. 3 months are enough. Socket grafting, here you can see the histologic. You can see the osteocyte. Beautiful, dense, lamellar bone, 3 months post-op. Even if you don't have the buccal plate, when you are within the indication, you place the material, don't mix it with blood because there is no need. Immediately the blood will come inside. Okay? 3 months later, this is vital bone of the patient. Now we need to remember, because of the replacement of this graft into the patient-owned bone, we're going to see complete different radiographic behavior. First day, it will appear radiopaque. 2-3 weeks later on, everything will disappear. Most of you are not familiar with this phenomenon, will be sure that you lost the graft, but actually, this is the osteoid before calcification. This shows you that something happened here. You continue to wait up to 3 months, and you see beautiful, dense bone in the area. It also can control bleeding. We can see it in this case, for example. There was an abundant bleeding during surgery. You can see artery bleeding. Now, when you have experience, it's time-consuming. When not, it's very frightening because it does not stop. So what I did, I just eject the material into the site, the 3D bond here, press it for 3 seconds. 3 months later, this is the bone. By the way, when you press it, it stopped the bleeding instantly. This is the outcome, 100% patient-owned bone. What could be better? So I took a video to the other part of this nice lady, and you can see the bleeding here, and in a few seconds, you're going to see the splash of the artery on the finger of my assistant. Take a look now. We eject the material into the site, press it firmly for 3 seconds, and stop the bleeding. Now, we need to understand that when we work with cement, we need to work with it as a bulk. We cannot take it a little bit and a little bit and a little bit like granules. It would not work. So change your way of thinking when you're working with cement. I continue to augment. I use here the 3D bond because I had enough bony wall surrounded. So for me, it was important to say, let's first stop the bleeding, and then whatever I will gain, I will gain. Even if I have loss of volume, in the other time, I can re-augment. But you will see very shortly, by the way, primary closure is essential. Don't leave it open. 3 months later, this is the soft tissue appearance. This is the new bone that was formed, and this is the re-entry. 100% the patient-owned bone. We can use it as well when we take a free connective tissue graft. Now, we don't use it in that case for augmentation. I'm using for such cases the half cc, which is relatively not expensive. When there is abundant bleeding, I just place it, press it, stop the bleeding instantly. It saved me at least 20 minutes that I need to stay until it will stop. And you can see that soft tissue can proliferate very nicely in the area. Now, another option is to use it for sinus perforation, accidental sinus perforation. In this case, you can see there was a quite large perforation. But I have the buccal plate and I have the palatal plate. Those are inclined a little bit, and the material, when it's encounter inclination, it cannot go through. It just condenses through himself. So it was very easy to treat this case. I just need to eject it into the site. And by the way, even if something will fall down into the sinus, nothing will happen because it's completely resolved. One thing is important, not to use it with infected sinus. Like with any graft, we don't use graft in infected site because there is no blood supply in the graft at the beginning. Press. That's all. Now, I didn't do sinus lift here. I just close it. No membrane is used, just primary closed. Okay? 3 months later, that's how it looks before. That's how it looks with the graft. And at the radiography, you can see that bone was formed there and closed the gap. Now, the other product, which is a combination of the HA, by the way, those of you who insist to continue to work with your graft, you can make a mixture by yourself to create your own cocktail. You know, it's like a nice lady that can go to the shop and buy an already made cake, or she can make it by herself. There are those who like to do the cocktail by themselves. There are very nice protocols. You can go to YouTube under Ogma Bio and find all of those protocols, hands-on protocols, if you use it by itself, or if you combine it by yourself, or if you use our second product, the Bond Appetite, the red one. Now I defined it as this hammer. it can be on-road and off-road. Indeed, it does not have the performance of the Bugatti, but still, it can do the work. Now, when we use a composite graft, when one matrix is resorbed relatively more faster, and the other just help to preserve the three-dimensional space, we're going to have much more vital bone than if we use just one of those grafts. And the technique is very simple, as you can see here. The only thing is to activate the material, eject it into the site, press for 3 seconds, and close the flap. Now, those of you who are concerned how the blood will come inside, you can see here the microscope image, which shows you that it has internal structure, microporous for 1 to 50 micron, and macro from 300 to 800 micron, which enable the blood to go inside. So no matter how much you condense it, you cannot block those pores. So don't be afraid to condense it. One thing is important for me to stress is when you do a socket grafting and you work with cement, when the socket has 4 bony walls, you eject the material into the socket, press it firmly for 3 seconds, but don't use any tool to condense it down into the bottom of the socket as you used to do with granules. Because if you do so, the patient might experience pain similar to dry socket. This is not dry socket. It's due to the expansion of the cement. But if you want to prevent it, first, press above, don't use a tool. Second, if it's happened by accident, especially if you're not familiar with the material, the only thing that you can do, place 2 drops of eugenol above it. It will stop the pain immediately. Okay? There are those who use, before inserting the material inside, they are use gel form, 1 or 2, and then they place the material. Now, how to work with it, this handsome guy will explain. Can you lower the voice? Well, I'm joking, he's not so handsome.
I myself am a clinician, the inventor of the biphasic calcium sulfate, and the CEO of Augmentation. In this video, I would like to demonstrate how to work properly with bone appetite bone graft cement. Working with bone appetite bone graft cement can simplify dramatically the way we perform augmentation procedure. The entire graft placement and stabilization can be done in less than a minute. The healing period is reduced to 3 months until you can place all loaded implants, and of course, no need for membrane coverage as long as the soft tissue is primarily closed and well sutured. So, only 3 simple consecutive steps are required in order to place or stabilize your graft. You need to place the graft, press it for 3 seconds, and close your flap. So let's get started. In order to be familiar with the material, we provide the training kit. The training kit includes training manual, 2 demo syringe of bone appetite, and mandible and dry goods. So let's get started. This is the bone appetite syringe. It contains the powder, the liquid, a shaft, 2 pistons, blue indicating line, and the syringe cap. Now, in order to activate the material, all you need to do is push the shaft against the palm of your hand and start pushing the piston until the first one reaches the blue line. At this stage, the material gains the right viscosity and is ready and prepared to be placed in the grafted site. Now, to remove the syringe head, all you need to remember to do is 3 simple consecutive steps. Place, press, and close. And in less than 1 minute, you can finish the entire procedure. Now, let's do it together. Approach to the defect site in 45 degrees angle and start ejecting the material into the grafted site in 45 degrees angle. Now, during the ejection, use the syringe head in order to help you to stabilize the material by a small condensing movement that you do with this already well stabilized. If you need to shake, you can shake it a little bit and press it again for 3 seconds, and you can close the flap. However, it's very important that your soft tissue will be primary closed and well sutured. That's all. Simple as that. Now, I would like to demonstrate how to work with bone appetite for socket preservation technique when you don't reflect the flap. Press the shaft against the palm of your hand until the first piston reaches the blue line. Now the material is already activated. Remove the syringe head, approach to the socket side, and eject the material into the socket. Slightly overfill it, and now you take a dry gauze and press firmly the material into the socket. Now, if there is not enough place for your finger between the teeth, use a spatula or an elevator aerosol and press about the dry gauze. Now, you cannot leave the material exposed. What you need to do is to take a barrier, which can be a simple collagen sponge, and place it above the graft. However, it must be sutured together with the soft tissue. So the technique is in that way. Hold the collagen sponge in your hand, insert the needle from the buccal aspect, insert it to the bottom of the collagen sponge, and from up to down, insert the needle into the lingual aspect, and place the sponge above the grafted site and make your first suture to stabilize the collagen sponge in place. Now remember that the collagen sponge must be stabilized together with the soft tissue by its first knot. After stabilizing the collagen sponge in place, or the membrane in place, you continue with a crisscross suturing in order to protect it in a better way.
Now, as you saw here, when you have a socket grafting and you don't reflect the flap, never leave it completely exposed, because then you will lose volume. Because don't forget that the material, the only time that it's hard is when you place it. It will never be hard like a stone, but it's very stable. Immediately start the transformation of the material, so then it will be more soft. Therefore, it must be protected. You see, when we release the flap, it not need to be tension-free, as we do with membrane. Just release it in the bottom of the flap, I mean, in the connective tissue, that it will be enough. Activate the material. You must work with it simply as we show you. Don't complex. Eject it to the site, press it firmly for 3 seconds, not more than this, and close your flap. You see that the blood is coming inside to the hygroscopity of the material. Now, if you have opening of 2 millimeter, it's okay, but don't leave it open more than that. Don't leave it 5 or 4 millimeter. As my daughter showed here, the only thing that you need to remember is this: 3. Place, press, close. And it should be consecutively. You place the material, you press it for 3 seconds, close your flap. That's how it was before. This is the bone that we're going to have. Patient on bone. Is it bone? Definitely we need to take some histology. You can see, you can see the quality of bone that we gain here. Now, radiographic appearance. Again, at the day of placement, it's radio opaque. How many of you would think that you have something here? How long time do I have until the end? You're done. You didn't give me even 5 minutes to do this. Okay. You're just done. Okay. Okay, so I'm done. Do I have 1 minute or 2 minutes?
Sure, 1 minute.
Thank you very much. So I will run a little bit here. Okay, radiographic appearance. No one of us will believe that is something, but wait a little bit more and suddenly that's what you see. The patient on bone is formed. You see also something very interesting, that the cortical plate is building again with time. So this is very impressive. Again, another case, I will run on it. Place the material, press, close for 3 seconds, close the flap, radiographic appearance. This looks disaster for those who are not familiar with this phenomenon. But at the re-entry, this is the patient on bone. And what you can see, that the big particles, like somebody shaped them because they resorb. Lateral augmentation, again, the same. I will not stay with the video because I don't have the time. When we have implants around socket and we want to fill it, don't do what you do with granules. Don't try to condense the material in between the implant and the socket walls. Just press it above, and that's all. Because if you do so, you might lose the stability of the implant. And this is the bone that we gain. Beautiful bone. Again, you see it here. Now, every implantology has its jewelry box. Definitely, as many implants that I did, my jewelry box get bigger. But you need to have a very strong tool to overcome those problems. So we place the bone appetite, and you can see the bone that is formed here 3 months later. If you want, you can add, in the second stage, another augmentation. Another case, that implant was removed due to the prosthetic failure, placing the graft. 3 months later, this is the bone that we have, no need for membrane. Now the question, can we do vertical augmentation and perimplantitis cases? You must remember, the material is very elusive. It can give you the feeling that you can do everything, but vertical augmentation cannot be done just by leaving the material there. There are special techniques with a rigid barrier, and then you can have a wonderful result, but please don't start with it. Those techniques, I hope that next time when you invite me, I will come and show some techniques about vertical augmentation. Perimplantitis is unpredictable. I can make a show off with some beautiful cases, but they're unpredictable no matter what kind of graft you are using. So please don't do perimplantitis with my material. I prefer that your failure will be with my competitors. So let me summarize. Now it's very extremely easy to work with because it's cement. It's significant reduction of our chair time. The optimal results, reduction of our healing period. Membrane coverage is not obligatory unless you love to work with membrane. It's reducing as well dramatically our cost. So I would like to thank you very much for your attention. This is our website. This is my private email. Each one of you, if you have any clinical question, please write it down. I am willing to answer for any question. I hope that I will know the answer. And of course, you can find us in YouTube, agmabio.com, LinkedIn, you can find it under my name or under Agmabio, and of course, in Facebook. I would love each one of you to be my friend on my Facebook. So thank you very much for your attention.
Thank you so much, Dr. Amos. Thank you.
Now I need to run to the airport. Artery bleeding, it's an anomaly. Normally, most of the time you don't see such a case. It's not the lingual artery. No, no, no. It's not the lingual. It's not infraalveolar artery. It's anomaly. No, I don't know which artery it is. It's just anomaly.
Thank you, Dr. Amos. Appreciate it.